Good afternoon or good morning to all. I hope everybody's taking care of themselves for this pandemic event that we're confronting. I am very proud and honored to be invited to participate in this. I should give thanks to the Portuguese Integrative Medicine Society for this invitation. My name is Oscar Puig. I'm a clinical nutritionist at Hope for Cancer, located in Tijuana, Baja California. And today's topic will be clinical nutrition and cancer. Will be our outline of topics we'll go through is malnourishment and cancer, conventional treatment and its effect on the nutritional status of the patient, nutritional therapy that we can propose in this case, and conclusions. We know that the microenvironments of the tumor or the cancer cell has its own inflammatory response and its own cytokines, as it was presented in this paper. This pattern of inflammation can promote not only will be a change in the appetite of the patient, but also the utilization of energy, prompting the patient to even break down muscle mass or fat mass in form of energy. This change in appetite can change the habits of the patient, presenting anorexia or will be satiety of the patient, or will be in this case changes in the pattern of digestion that can not only reduce will be the pattern of absorption and digestion, but it also in this case constipation, for example, right? Considering the common therapy that the patient can be prescribed will be in just the typical environment, medical environment. Oncotherapy as chemotherapy or radiotherapy presents its own challenges that can complicate even further the state of nourishment of the patient, and we'll go through that in a moment, right? We know that the metabolic environment of the cancer cell is its own environment. It can go through this anaerobic glycolysis and recycle the process of sugar into will be lactated and actually fermentate this pattern. This lack of oxidized phosphorylation increases the process of lipolysis, gluconeogenesis, the pattern of degradation of protein, and the probable insulin resistance that it could promote in the long term. Now, understanding this part as a part of process of inflammation is key, obviously because of the lack of oxidized phosphorylation, right? This fermentation process of lactate, or this Cori cycle that can be produced, is very individually or unique to the cancer cell. The proposition of reduction of this type of substrate, as will be sugar, is a novel therapy that we can introduce, right? Where we can try to reduce the carbohydrate content of the diet or present the ketogenic diet to the patient, which we know that the fatty acid metabolism cannot be related to lactate, since it cannot produce lactate, right? This process of producing energy via glucose by the cancer cell creates a instability not only in the oxidative pattern, but also in the metastasis of the cancer. So if we reduce what will be the pattern of substrates with what will be the reduction of foods that can rapidly increase a glucose curve, we can really help to manage the growth of the cancer with the patient, right? Naturally, this idea of prompting the patient to a ketogenic diet can cause a lot of implications dietary-wise. Trying to assess the appropriate timing to introduce a ketogenic diet is critical, because again, depends on the patient how he's presented or she's presented. It's something that we should always use as a tool rather than just a soul-based diet. Really, the ketogenic diet is based on the environment of the patient and the tolerance of the patient. Now, we can also produce ketones and survive with ketones if you introduce fasting with the patient. Not necessarily go to a ketogenic diet, but introduce this pattern of fasting, which can promote this utilization of ketones, right, without altering the percentage of macronutrients and changing radically the diet of the patient. Now, we know that when a situation is presented as an inflammatory condition, there's a cascade of events that can occur in different tissues. Now we'll talk about now how it changes now perception in brain. Now there is a common symptom of anxiety, depression, and anorexia with patients in cancer. There's a change in the metabolism of energy, like we mentioned, that Cori cycle of that fermentation process and recycling of lactates, which alters the whole state of energy production of the patient, leading to a lot of fatigue, and again, a lot of other symptoms. Now, the skeletal muscle is affected because, again, there's a reduced protein synthesis, and there's more degradation of protein in the patient. So there's a situation that we'll talk about right now in a moment, which is very common and present with our patients, which is sarcopenia. Now, the Latin word of sarco is muscle, penia, loss, which we used to correlate it to process of aging. As we know, there's a reduction, a large percentage of reduction of muscle mass as we age, because it involves a lot of habits like lack of physical activity or the inadequate nutrition. But we know with tumor progression, this inflammatory response, this change in hormones, this metabolic change in energy production promotes this utilization of degradation, I should say, of protein in the patient, right? This pattern of sarcopenia is actually something that we can misdiagnose all the time because we do not have the proper tools, right? There's obviously testing that you can provide to your patients to really understand their overall composition, body composition, and also their dietary habits. You can use screening tools, like example, the mini nutrition assessments. You can use what will be the sarcopenia assessments. You can use a standard bioimpedance analysis machine. You can use a what will be a screening for what will be lower and upper strength of the body and stability of the body to really know what will be the density of muscle mass that the patient has with a short performance, battery of performance and physical activity, sorry. Or you can use the DEXA scan if you have available, or you can easily use calf circumference and brachial circumference to really kind of tell you what would be, in this case, the amount of muscle mass that the patient has. Really something that we always misdiagnose in cancer. So I invite a lot of, in this case, our viewers, if in this case you're treating cancer patients, these are areas that your nutritionist or dietitian can apply to really improve not only the treatment of the patient nutritionally, but also improve the treatment of the patients with what would be any typical medication or any other therapy that you would provide. It's widely known that the lesser muscle mass that the patient has, obviously the worse outcome that the patient will have, because again, the lesser muscle